We're now moving on to our next keynote speaker, who is Stephen Shortell, professor of the Graduate School, Blue Cross of California Distinguished Professor of Health Policy and Management Emeritus, and co-director of the Center for Healthcare Organizational and Innovation Research at the University of California in Berkeley. And he will talk more about innovations and how innovations can actually be sustained and built upon with examples from around the world. So, Stephen.
Thank you, Victoria. So I'm going to take us on a very quick, maybe 20-25 minute journey over 20 years, actually, of learning. What have we learned about integrated care? Some of my comments will build on what Henry has just shared with us, and then I think we're going to have a few more questions as well to comment on some of that. So let me get started, and here's the outline that we're going to go. So Henry talked about a cow. I make the metaphor really of integration in terms of the holographic organization where you can see the whole embedded in each part. I'll unpack that a little bit. I'm going to talk about medical and social services, the challenge of that. It's challenging enough to integrate healthcare services, but now, as we all know, it's really about the integration across the continuum with the social services as well. Some examples, some you've already heard at this conference: Germany, Spain. Won't say so much about the UK, Brexit, I don't know, my UK colleagues, forgive me. Say a little bit about the US. Somebody, or a lot of people, I guess, were interested in the ACOs in the States, so I'll comment briefly on that. But I really want to save time at the end also for future directions that I think we need to go in. So the idea of this holographic organization is the whole embedded in each of the parts. You turn it, you see it there, you turn it, you see it there. Wouldn't it be great if people experienced that in terms of the point of entry into the care or social services system? That part knew what all the other parts were doing. I mean, Henry talked about maybe get all the people in the room together. So how do we create, big challenge, a holographic, if you will, care system? So some ideas about that as we go through this. I also want to take us back 20 years, right? 1999, there was a seminal article in the Millbank Quarterly by Walter Lutz, and integrating medical and social services. And he developed some ideas around that, some of the laws around that. And one of the things I want us to think about is, to what extent have we actually learned? How much have we learned over the last 20 years? And I'd like to suggest that in some cases, it seems like relatively little. In other cases, maybe more so, but that's for you to decide. And how do we accelerate the learning that needs to occur? One thing to talk about, Lutz actually talked about it, is you can see here, is there's different degrees, if you will, of interdependence or integrating mechanisms. And he talked about, for example, linkage, coordination, and then full integration. And in interest of time, if you just look at the information under the linkage area, you provide it when asked and when needed. You don't need anything more than that. Don't waste time or effort. Coordinated, you have to define and report in both directions. So the nature of the work is what some people call reciprocally interdependent, not sequential. Right? So the patient, the doctor, you need to feed it back, et cetera, you need to coordinate. But integration, getting towards this idea of the holographic, the holes in each part, would be a common record, electronic health record, electronic health social record, that's a part of daily joint practice and management. Okay, so keep those distinctions in mind. He developed from this 5 laws. Some of you may remember these. Resources are constrained, right? Therefore, important to target. And this has come up in a lot of presentations that I've participated in today. Stratify. Not every patient needs fully integrated care. It's the 5% that account for 50% of costs in most countries. It's those with multiple chronic illnesses. It's the frail elderly. It's those with mental health problems. That's the focus. That's where we really need to integrate. Secondly, it's not free. It costs. One of the reasons it's so difficult to do and redesigning the care continuum is not just the money involved, but the time and resources other than money to actually think differently about how you keep people well. So it takes a real resource investment. You need to recognize that your integration is creating a ripple effect for others that maybe further fragment their job, okay, as it were, because of the interdependence involved. And by the way, speaking of fragmentation, just a sideline here. Come to the US, some of you have been here, I know Harkness Fellows and others, we specialize in this, fragmentation, right? So if you're a Medicare patient, 65 and over in the US, on average, you see 7 physicians in a given year, and they are in at least 4 different practices, okay? If you're hospitalized today, a Medicare patient, 65 or over, and you are asked, do you know who's in charge of your care? 75% of our people do not know. They cannot answer. They know maybe who their primary care physician was, but it wasn't that person who admitted them. Maybe it was a specialist, they're not sure. Maybe it's the hospitalist who hasn't visited them yet. I don't know who's in charge of my care, okay? The average primary care physician in the US in the course of a year has dealings with about 200 other physicians, multiplied times all the patients they see. And those 200 physicians operate in about 120 different practices. 20% of our Medicare patients get readmitted, okay? And the cost for us is about $140 billion a year. So fragmentation, okay, don't do what we do. We're working on it though, we really are working on it. You can't integrate a square peg and a round circle, okay? You can't integrate a square peg and a round circle. How similar are the services that you're trying to integrate? And maybe more important is how similar are the organizations that are trying to integrate? Different cultures, how do you develop shared goals, mutual respect, timely, accurate communication, frequent communication, problem-focused communication. Some of you may recognize that as relational coordination. Jody Gattell and others have developed that concept as well. Realization you need to do some things differently. And there's a new law, 20 years ago, Walter Lutz said, you know, the payers really aren't getting this and there's no financial incentives and why should people do this hard work? I think that's changed. It's certainly changed in the United States. I think it's changed in many of our countries. We're spending a lot of money, and what are we getting for it? And increasingly, they are calling for the integration tune, okay? They are calling for the integration tune. So I think that's one of the new laws. He had 3 or 4 recommendations, and I've added a couple of these. Involve a wide variety of stakeholders up front. Who needs to be at the table? Begin with the patient and the community and the population-based health needs assessment. Develop systems to integrate, coordinate, and link. Henry alluded to systems, right? So systems of care. The need for systems thinking among our leaders and managers. And maybe we can talk more about that in the questions and answers. Really important to clarify the borders between the medical and social service systems, right? Who's responsible for what? Where do they overlap? How are we going to manage the overlap? Let's talk about this. Let's role play exactly. We get this kind of patient. Who's going to do what? What's the primary care physician's job? The social worker, the clinical psychologist, the community health worker. What's our common language? What's our common understanding? How are we going to resolve conflicts and honest differences? We need to spend time doing that. And then I would add 2 new additions to the original ones, and this is where maybe we have begun to accelerate the learning, and that is the challenge of interoperable data. We now have, with the technological advances, the electronic health records, et cetera, and we're beginning to break down the barriers to sharing that information, both technologically, but also in terms of privacy issues, protecting privacy. but having that information available as much as possible in real time. So the person with 3 or 4 chronic illnesses seeing these 7 doctors, at least they're working from the same electronic health record. And that doesn't solve it really, because they're accessing it at different points in time and they don't necessarily have a way of summarizing that information or how to use other kinds of health professionals who can do that for them. So that would be one addition. And then the need for systems thinking leaders. Okay, yes, leaders need to be managers, managers need to be leaders, but that's a continuum. I disagree with Henry a little bit. Not everybody has the same set of competencies. There's comparative advantage. The key point is to recognize your limitations. And you don't have to be the big hero, even though you may have the official office to make that decision. But instead you recognize as a leader, somebody else is better at managing that, and I'm going to have them do that and let them take the credit. Okay, let them take the credit. So we can talk more about management and leadership. So 18 years ago, these were some of the early lessons. Nick Goodwin, Professor Goodwin, here they are. And what I'm going to do after this is go through 5 or 6 more slides of more recent studies, some of the lessons learned, we think, and I bet you can map them onto these here for the most part. Some will be a little different. We can unpack some of them. How do you work towards shared goals? Okay, really critical between competing, perhaps, social service agencies, hospitals, and health systems. Common vision and strategy, okay? Joint funding and planning is certainly going to help. If you don't have joint funding, it's not impossible to get some degree of integration, but you're going to have a much more challenging path. And then joint delivery, again, what we've talked about, the trust, the leadership, the clear governance. Evaluation, I'll be saying more about that in a few minutes. Evaluating, visual management, feedback, so how well we're doing and finding that out quickly. The quality improvement advances over the past 15, 20, 25 years in the UK, the US, Institute for Health Improvement, others around the globe, really PDSA cycles, learning quickly. We don't need a bunch of randomized trials and wait 2 or 3 years till it's in the BMJ or the New England Journal of Medicine in order to take action. And then finally, the quality improvement processes that I've alluded to. That's what Nick concluded about 18 years ago from the studies that he did and his colleagues in the UK. Okay, so let's update this. Let's update this. Anything new? Well, here's some of the summaries of some of the work in the US. And you can see here, closely targeting patients most likely to benefit. I underscored that earlier. It wasn't on Nick's list as such. Comprehensive assessment of their needs, not just medical, but an example that Henry talked about of not what's the matter with you. I've got 15 minutes. I need to diagnose you. Tell me what's the matter with you, et cetera. Why aren't you taking your medications? No. Let's stop and figure out what's going on with your life. Who are you as a person? What's your family life like? What do we want to achieve together? So it's really what matters to you, what matters to you. Comprehensive assessment. Specially trained care managers, really important for managing the transitions from hospital to post-acute to home to rehab. We need a new kind of person in order to do that. Effective interdisciplinary teamwork and resource allocation. Whole lectures about teamwork, and you know a lot about that. And the ability to manage patients across multiple kinds of settings. So that was recent work that's been done in the US. Post-acute care, you can go through some of these bullets. Bundling payments for entire episodes of care, create a common incentive, economic incentive. Stratifying patients, I mentioned earlier, by risk. Standardizing patient education while still tailoring it to the patient's needs and preferences, but not everything has to be like a new prescription. In-home support, hospital at home. More can be done with the technology now, wearables, implants, and so forth, so the patient can stay at home and try to continue to live independently, not be in a nursing home or a hospital bed. Use of community health workers is growing in the role of home health agencies. Other evidence, this is a recent article a few months ago in Health Affairs, embedding physicians across these different settings. So again, you get the holographic idea. Yes, I practice on the medical staff of this hospital, but I'm also a day or two a week on the staff of the skilled nursing facility, and I'm charged with sort of integrating what needs to occur between these two institutions for the patient. Shared electronic health records, regular meeting with skilled nursing facility leadership, dedicated care coordination staff, and again, visual management, data collection and monitoring. So let me talk a little bit about Germany and Spain, and then quickly the US, and then begin to wrap up a little bit. So Germany, and we have some folks here, and this has been talked about, OptiMeds and the Kensital model, some key lessons. This is very recent, 2019, at the start of the year. Important to have a regionally based integrated organization. In the United States, we're developing these accountable communities for health that include not just the hospital health system or the health department, but housing, transportation, the schools, community development, and so on. But there's a backbone integrating organization that holds the accountability. They bring the people to the table, and they have the information and the resources. And what they're trying to do is keep the community, promote the community, and the conditions that increase the probability of people being healthy, and not just fixing them up after the fact. Both, of course, are important. Considerable startup investment was a major lesson of the German experiment. At least 3 years needed before you get traction. And we're an impatient people, particularly in the US, but I think it's also elsewhere where you need instant results, politicians come and go, etc., and they have their own ideas, and if you can't produce results in the first year, maybe you're out. So you have to fight that. So population size is important. They found that you really needed at least 100,000 people in order to make some of this work. Comprehensive information technology, predictive analytics, where you're getting the data and you can drill down on it to prospectively, with a population, make some predictions on who's going to become ill in various degrees over the coming year. And I mentioned earlier the 5% with 50% of cost. It's very interesting. That's a cross-sectional kind of thing. In the US at least, and I don't know what it is in some of your countries, but you can calculate it. In the US, about 20% of those people will continue the next year to be in that high morbid category of generating those costs, about 20%. The other 80% come and go. I mean, some die, but some get out of that category through various interventions that have been undertaken. So to identify that 20% that are going to be with you for quite a while. And business models with payment that rewards health outcomes, again, incenting the integration of medical and social services. So Spain, we just had a session. We had a project at Berkeley with our Spanish colleagues, and we went through some of this earlier. Some of you were there. They have an overall framework that they developed, getting at the relevant stakeholders, bringing in those stakeholders. They do a great job at stratifying patients. Who do we really need to pay attention to and not waste our resources? Personalized care plans for complex chronic patients. And so these plans are available for all the caregivers and providers in the system. Integrating health and social care in schools. They've been doing a number of experiments in that and looking at the results. Integrating different sources of payment. If you can't do it up front, can you do it at the point of service where you can take money from here and everybody agrees with that to keep the patient well or to keep them out of the health system by giving more of the budget that may originally have been in the health system to the social services system, or maybe vice versa as well. And so kind of braiding the money together. And then also they have the ability to negotiate drug prices for all of Spain. Some ideas there. The United States, accountable care organizations, when they started, and I and others were involved in developing the legislation that made it into the Affordable Care Act. I remember there was an early article that came out, these ACOs, that they were really like unicorns. You know, everybody kind of fantasizes about them, but no one's really seen one. Well, they've grown to over 1,000 now in the US. They serve 32 million people. They're in every state as well. The evaluations are such that after the longer you're in, the more shared savings you get. By the way, the ACOs create an expenditure target up front. They deliver care under that target. They share in the savings with CMS, our Center for Medicare and Medicaid. Some of them are now going to downside, so they lose money as well. We're beginning to get away from fee-for-service, going towards these kinds of expenditure targets up front. They have to hit quality indicators first. You don't stint on quality. Besides, if you do, they're going to end up in the hospital anyway. It's going to cost you more money, but there's quality safeguards as well. And so these are some of the experience to date. Probably a savings of about 1.5% over time. That doesn't sound like a lot. That's a lot of money. That's a lot of money when you multiply that out. And quality, if anything, has improved. Quality, if anything, has improved. So these are continuing to grow in the U.S. They haven't met some people's expectations, again, because we're impatient. You know, it's like, well, gee, you know, after 5, 6, 7 years, you're only getting 1.5%. You know, et cetera, et cetera. And so there's arguments about the pace of change. How fast can we change to get more people involved? The UK, interest of time, but they're doing a lot of this as well. The transformation partnerships, the pioneers, and I know there have been sessions on that here. Okay, 2 or 3 final slides, and I'm going to wrap up. Where are we going to go in the future? How can we get more learning? How can we leverage this conference, for example? We do need to do, I think, some more rigorous evaluations. And even to the extent that in some cases you can think about randomized experiments, randomized studies where you have a health system and you have something that's not clear it's going to benefit people. Why not randomize? One of the advantages of being a system is you can learn. You can accelerate learning. So those opportunities may be small, not a lot of them, but we shouldn't ignore them. But certainly we've had advances in propensity score matching that we can capitalize on, various econometric techniques as well. We really need the other point there, longitudinal data over time, the ability to get enough funding to track over time, which I'm really encouraged in the UK. It sounds like some of the evaluations are taking place that way, in Germany as well. We certainly need more of it in the United States. The need to study newly emerging digital technologies. So one of the sessions I was in today was around our rural populations in our different countries, right? So I think we're in the age now of distributed care. Susan Dentzer, who's a US kind of health commentator, has written a book or edited a book on this, which I recommend, on distributed care, telehealth, the wearable technologies, how we can get better care in rural America by making good use of telehealth, licensing laws, making sure nurses and others can practice at top of license and so on. This is the wave of the future, one of the waves of the future. And at the conference next year in Toronto, I hope there are some sessions on distributed care, which sounds like the opposite of integrated care, but I suggest to you it is not, although it will pose challenges, right, for the integration. But this is one way of dealing with the rural populations. Then, how do we take advantage of the advances now in artificial intelligence and machine learning? Maybe there is a session here on that. I don't know. I didn't see it if there was. But there should be next year. Okay? So how do we take advantage of what we can learn by feeding a lot of data and using the various algorithms and getting out information that can really be turned into knowledge and be turned into action as well, is an area that I think is emerging. And the role of patients as co-designers of care, absolutely, we need to learn more about that. And cutting across the board in all of our countries are the inequities, in particular by racial and ethnic group and socioeconomic status as well. Harking back to Sir Michael's comments this morning, it cuts across everything that I've said or I intended to. And part of that stratification, okay, is really overlapped with a lot of those other things I mentioned, because it is the poor living in communities that are not conducive to health. So next to last slide, I said something about virtual care, telemedicine. I'm just going to highlight a couple here. Up here, if this does it, somewhere? Yeah, whoops. Well, let's see if we can backtrack that. There we go. So ongoing treatment for chronic conditions, you can see remote patient monitoring at home, right there somewhere. 70%, this was a survey of 700 physicians in the US, and 70% thought that very much it could be used for that. 67% for patient portal, and you can see across the board. So chronic conditions and then follow-up appointments are the greatest use, at least in the US, of some of these virtual care and telemedicine. So let me just end by summarizing maybe 3 or 4 things that stand out in my mind. 1, stratify. Really know your population and what their needs are. Secondly, really important are the data and the information systems at point of care that can begin to be used in order to do the team building. Third, our resources are going to be needed. It's going to cost to invest. What do you let go of? You have to let go of some things in order to try new things. And fourth is the time. You need to give things time. You need to stick with it. You need to be persistent. And I would end with 3 questions, which actually come from strategy, not strategic planning, so underscoring what Henry has said, and that is really be serious. What are you trying to achieve? And to what extent is that bought into by all the stakeholders? Are you in agreement? Secondly, what needs to be, or secondly, what will success look like? What are going to be your 2 or 3 critical metrics at different points in time? And third is what needs to be true for that to occur. And when you examine that, you begin to see, oh, that's not going to be feasible. What's plan B? What's plan C? So you don't set yourself up for failure, right? So you really do that homework on those 3 questions. Thank you very much.